and I'll be looking at facilitating this session where we're looking at metabolic complications of alcohol in cholera individuals. So could you just give me a sign if you're able to hear me? Maybe say hello or something so that we know it together.
Yes, Dr. Kozia, we can hear you.
Thank you, Dr. Dalal, for joining us. We are looking forward to your session. Thank you, Emmanuel, for raising your hand and giving us a heads up. Okay, so today we'll be looking at a very important session, which we feel is an important component in the management of cholera, because we've had a number of our patients who use a lot of high use of alcohol that we've lost, and we wanted to make sure we build capacity among our staff that are providing clinical care services to those people that are coming into the cholera treatment centers. And so with me is Dr. Sivile, and we do have 3 sessions. We'll be looking at a metabolic complication of alcohol in cholera individuals. Then we'll also look at managing alcohol withdrawal syndrome, delirium tremens, and this will be done by Dr. Dalal. Afterwards, we are going to have Professor Mulenga who will come and then he will share with us antibiotic management of cholera. We also noticed that there's been quite a bit of a confusion there as well. So we will have a very exciting afternoon, and we hope that you'll be able to stick around as we run through this session. So Dr. Sivile.
Good afternoon, network. Pleasure to be here again. Unfortunately, we're still in the middle of an epidemic, and we are noticing a phenotype of patients that we are losing, and we'd like to spend some time discussing that. The next slide.
All right, thank you so much. So just to also say that we are being joined by a panel of experts. Dr. Agramemba will be joining us, Dr. Edford Sinkala will also be joining us, and Mr. Mpanga will also join us. They'll also have an input on this discussion. And in the hub, we do have Dr. Kalunga and Dr. Chimikapiri, just also available in providing support to this session. So moving on to the next slide.
Yes, so this typifies a real patient. This is a phenotype that concerns us. We lost this patient. So it's a male, 55, admitted with cholera and severe dehydration. He had a strong history of alcohol misuse. Prior to his referral to Heroes Main Cholera Center, he had repeated episodes of hypoglycemia. He was noted to be confused with visual and tactile hallucination at day 3 of admission at Heroes, which was treated with thiamine and diazepam. I didn't put the doses there deliberately. His conscious levels continues to reduce till he had a cardiac arrest at day 6. On his last view, that was 3 hours prior to the cardiac arrest, he was well hydrated, normal pulse rate and volume. Glasgow coma scale was 8. He was in a coma now. He was hyperventilating. RBS was 6.8. Lungs were clear. No other lab tests were done. As you know, you are in the center, and sometimes it's difficult to do that. And we lost the patient from the cardiac arrest 3 hours after that. So which of the following conditions could explain his progressive decline in consciousness? Feel free to give what you think is the answer. You can have the poll.
Very, very, very a real case. These things that we are seeing in the Heroes Cholera Center. And we are hopeful that during this session, you'll be able to pick out something. And this is just something that we want to address in the session. And so please go ahead and poll which of the following conditions could explain his progressive decrease in consciousness. So you can just give it a guess if you don't know. If you know, try your luck. I see lots of activity going on. We have about 445 55 connections. So and only about 178 people have voted so far. Let's try and push to half of our attendance, maybe then we can move on to the next slide. We've managed to hit half of those in attendance, and it's been now over a minute now. I'll give us a few more seconds before we end the poll. Okay, so we'll end in just the next few seconds. Okay, great. Thank you everybody for polling and taking a shot at this poll. We'll end the poll and let's see how our results look like. Okay, so which one of the following could actually have led? Most people thought it was alcohol, ketoacidosis, some delirium tremens, some think it's Wernicke's encephalopathy, hypoglycemia, electrolyte imbalance, cerebral edema, whilst most people, about 32%, thought it was all of the above. We were yet to find out. Dr. Severe.
Thank you, Dr. Ziambo. So I think this is just to show that probably the relationship or the management of alcohol, people who take alcohol in an immoderate way might not be easy when they develop cholera, especially when they're severely dehydrated. And this is probably the message that we want to take and what we've noted back. Slide. So the relationship between cholera and alcohol begins from really the famous 1831 epidemic in Britain, where it was actually noted that heavy drinkers were predisposed to the acquisition of cholera, and probably the outcomes were not as good. And some people actually postulated that maybe it was a punishment of God for being alcoholics. Yeah, and there were some messages and some interventions that were put in place. In Tanzania, for instance, in the 70s, they even banned locally made alcoholic beverages because it was noted that people who consumed that, the outcome was worse, and they were more at risk of getting the cholera, which we are unfortunately seeing in this epidemic as well. Unfortunately, some people also thought that alcohol was a cure. It was an unproven remedy they were using at that time. You can see from the picture over there, some cartoonists showed the so-called alcohol brandy that they were using. Some studies were done subsequently to show what was the relationship between alcohol and Vibrio cholerae, and in ex vivo it was shown that actually it's lethal. But in humans, you find that high ethanol use will prevent gastric excretion, and that aclohydra in the stomach will kind of promotes the proliferation of the Vibrio, and this is now postulated to be the cause of that relationship, why we see alcoholics getting to be more at risk, or people who abuse alcohol to be more at risk of getting cholera. But lower amounts of ethanol seems to promote the use of the excretion of gastric acid, and the pH of the stomach gets to get lower, and this tends to prevent the proliferation of the bacteria. There are other things which could be at play in this relationship. For instance, in locally made alcoholic beverages, for instance, If you go to our communities right now, some of the people use locally brewed like cachaça. You find that at the point of mixing or diluting, they might use water that is contaminated. And even when there are people who are in this practice of alcohol abuse, there might be some lack of hygiene, with the foods that they are consuming, partially cooked food, braais and so on and so forth. But poverty is a big confounder, lack of clean water, and probably drug abuse. They do go together as well. So the relationship is quite strong historically and what we are seeing in the epidemic. But I think the message from the onset is high alcohol use is associated with high mortality and morbidity across all diseases, something that most of us as health practitioners should be aware of. Next slide. So this is just to go through the metabolism of alcohol. We know that alcohol dehydrogenase, metabolizes alcohol into an aldehyde, which can change into an acetate, and later on in the mitochondria will be changed in acetyl-CoA, which goes in the citric acid cycle and produces the glutamate. This glutamate is what gives us that euphoria, as the inhibition when it works on the GABA receptors. There are other non-oxidative pathways through the fat line, but this metabolism has got two consequences. One of it is the production of these reactive oxygen species, which are lethal to the liver and causes the cirrhosis, as we already know. But also there's some reduction because of the consumption of the NAD. By that acquisition of that hydrogen, it does reduce gluconeogenesis, and these patients are predisposed to hypoglycemia. So gluconeogenesis does go down. This is just where, amino acids are used up to form glucose, but this doesn't, happen. There's also, like I've said, the production of lipids, as you would know. Next slide. So what are the consequences of high alcohol use? I think this is just, we want to show that a patient or a host, as we would look at it in infectious diseases, a host-patient relationship, a host pathogen relationship. So if you look at the host for cholera, who's an alcoholic, there are other metabolic changes that are so critical to how will determine your success when you're treating this patient. The first thing is the malnutrition that comes due to alcohol. And this is really due to the decrease of caloric intake. Alcohol itself produces some form of calories, but eventually most of chronic alcohol misusers tend to lose weight because of inadequate intake of calories, and by and large, by also impairment in digestion, impairment in absorption. There's a loss of the villi. The appetite goes down because of the increase of the leptin and other cytokines. There's some effects in protein synthesis itself and secretion, increased catabolism of the gut proteins as well, and also the excretion of nutrients tends to be higher. But the ultimate result for this is these patients tend to have some protein calorie malnutrition, which we know that has got a big impact in the outcome of individuals. This is more worse, actually well described in individuals that tends to have alcoholic liver disease, which all of us should be aware of, that this is quite common in these hosts, and also those who develop chronic pancreatitis because of alcohol misuse. And this tends to be compounded, especially in those with chronic pancreatitis who have some of the micronutrient deficiencies, especially B12, and obviously you have also other water-soluble vitamins that will be deficient, like B1, which is thiamine. Almost 80% of chronic alcohol users will have this, mainly reduced intake, but also loss at the and reduced absorption as well. Other vitamins, B2, B3, B6, folate, like I've said, B12 would happen, and even things like B12 can cause some coma in severe cases. But the common one, obviously, would be B1 thiamine, which will take you through to the Wernicke's encephalopathy. Next slide. Again, just to emphasize that when you have these individuals, you need to pay attention to the malnutrition status. And this is just a guide that you can use to assess this individual. You know, once you find that they meet the criteria of protein energy malnutrition or calorie malnutrition, it might not be as easy in the outcome as treatment. The commonest risk that you have if you have to give large amount of glucose because they'll come with hypoglycemia, you send these patients in the refeeding syndrome, which will have hypophosphatemia. And this is, you find that chronic decrease in the Glasgow Coma scale, and you have other things that comes with that also, these disorders in the potassium as well. Next slide. So concerning electrolyte imbalance as well, so we know that chiefly alcohol has an effect on the hypothalamus there, where the ADH excretion does go down. So you have the loss of water at the kidney level because the aquaporins are not inserted. You also have alcohol direct effect of, you know, a diuretic effect at the kidney level, you know, and also you do have, especially in those who have chronic liver disease, they're in this state of hyperaldosteronism. The effects of that is that chronic alcohol users are in the chronic state of dehydration, and they have this intravascular volume depletion. So you'd imagine if you have such an individual and they get cholera gravis, you know, so it's a compounding on an already fluid depleted individuals, and this will be associated with other electrolyte imbalance. You can have other hypo or hypernatremia. Those who have a chronic liver disease, again, chiefly they will be in this chronic state of hyponatremia. And if they are losing, even if in cholera you have chiefly isotonic loss of fluid, but you can have further loss of sodium, and hyponatremia becomes a big problem in these individuals who are, you know, in that not normal state before they even get the infection. The other common things that you find in our alcohol, chronic alcohol users is hypophosphatemia. And this is classically described that it might not be very apparent before admission, but about 12 to 36 hours after admission, you will see the phosphate starts going down. And commonly, is due to a reduced ingestion, reduced uptake at the proximal tubule chronically, the acidemia as well, and also the refeeding syndrome, like I've mentioned. This will cause the phosphates to start moving back into the cell, and you have this chronic hypophosphatemia. The results of chronic hypophosphatemia, as you remember, phosphate is the molecule that is used to the production of ATP. So you know that the ATP levels, especially, you know, at the nerve levels, you know, the nervous tissue level will go down, and this patient will just fall and decrease down into this coma. And if this is not treated, this can be fatal. Hypomagnesemia similarly could occur, hypocalcemia, acidosis, and alkalosis as well. Alkalosis goes together with chronic liver disease, and also those patients who do have withdrawal, they tend to have hyperventilation, and they tend to be very difficult to manage. Next slide. And obviously, we have to, as we had a discussion here a few weeks ago, that cholera itself does have a lot of acid base and fluid disturbances. I think this was well presented by Dr. Mwemba a few days, I think 2 weeks or a week ago. And you, again, the issue is you have an individual who has some of these electrolyte or acid-based disturbances prior to the insult of the cholera, and you'd imagine that the outcome will be very, very difficult to manage. Next slide. So there are some important conditions that we need to consider. The first one is the so-called alcohol ketoacidosis. So as we showed in one of the slides, that these patients are depleted in gluconeogenesis. So the glycogen levels, they tend to be very low in alcoholics. Because of that, glucagon, as you know, which is supposed to help with the recruitment of glycogen into energy, will be very high as a response. Glucagon will cause insulin to go down. Insulin drop or depletion will cause lipolysis, which causes ketone body formation, which we very know the three of them, hydroxybutyric acid, acetoacetate, and acetone itself. And this gets to be elevated and produce some acidosis. The other thing that happens, we know that NAD is depleted in individuals that have alcohol, chronic alcohol use, and this compounds on that failure to have gluconeogenesis, so that there's production of glucose in the body, so that the insulin levels, they tend to go down. Hypovolemia will cause the limitation of the excretion of ketone bodies. So you would imagine that this would happen even in a patient that doesn't have cholera. But if you have an individual who gets cholera gravis, they're in shock, this tends to be worse and very, very difficult to manage. However, if you go through literature, you find that this is a phenomena that probably has not been well described, but we are seeing this phenotype of patients in the centers, and we are having challenges in managing them. The challenge is that the main treatment of this metabolic state is glucose replacement and a bit of hydration, but this will have make the patient prone to hypophosphatemia, even one case encephalopathy, if you go and overzealously replace these the glucose. Other complications, cerebral edema and hypokalemia, as you know, as you are reducing that acidosis. Next slide. There are other conditions, delirium tremens, which is going to be described. Most of these individuals as well have chronic liver disease, and they can tip because of the dehydration into hepatorenal syndrome, which is very highly fatal. We've talked about the malnutrition. Some of them would just have decompensated chronic liver disease. They get to go into fulminant hepatitis as well in the center, which will need, they'll have hepatic encephalopathy, and which is slightly difficult to manage if not in a good center. Next slide. So we do have unanswered questions in a cohort that have cholera and severe with the dehydration. How much dose of thiamine should we give those who have alcohol withdrawal? One would think that because of the metabolism that is noted, the doses should be slightly high. This mix of the acid-base imbalance, we don't have very good laboratory support in the centers to follow these up. How do we monitor fetal? It was supposed to be fetal electrolyte imbalance, like hypophosphatemia, which we are not measuring, and how do we treat really the hypoglycemia? We see these patients, they do have hypoglycemia, which is very, very difficult to manage. Some of them we had to put them at hourly glucose monitoring, the way you treat somebody who is in DKA, maybe they might need glucose infusion chronically, but you have to balance that again with the other electrolytes that we are giving, and which is just the question, what is the best fluid to manage in view of you don't want to give, say, something like 5% or 10% dextrose in someone who has cholera, because you aggravate other complications like the hyponatremia and hypokalemia and so on. So with that given, the point that we want to prove that we have this phenotype of patients that are quite very, very complex to manage, and we are losing them. Next slide, because of this metabolic state that we are sharing here. Next slide. So what are our recommendations? Our recommendations are simple. In the centers, we recommend that if you have such a patient, let us move these patients to higher centers here in Lusaka. We recommend Levy. Levy is able to do blood gases right now. They're able to do everything, and we are having it even in the COVID, and also the CTUs, the isolation centers that we have. Please, we are losing a lot of these patients. We want to reemphasize that rapid use. Let's not be overzealous with giving a lot of dextrose. Might not be a good idea. Some authorities, most of the authorities actually recommend that you avoid that practice before you give thiamine, even that when you do not know the status of the phosphate, it might not be a good idea, because you can rightly push the patient into that feeding syndrome, even with just a bit of the meals that you are giving. Electrolyte imbalance, like our group said, is something that we are not doing. We recommend that we probably improve on, and the acid-based monitoring. But we want to say that small, guide that I've given for nutrition assessment, even for adults, it's given. And if you find somebody who's in that state, the treatment probably should be instituted together with a nutritionist. Obviously, we recommend, as you are going to hear from Dr. Delao, messages to reduce these alcohol use in the community. Let's look out for alcohol-related comorbidities. Chronic liver disease is common in these patients. You can look at the signs of chronic liver disease, starting from the nails, the face, the chest, everything. And we are seeing these patients with a bit of ascites. Others have paratomegaly. They have, finger clubbing. I think a patient, we know all the signs. So we cannot do important tests like ultrasound in some of these CTUs, but our clinical acumen, is very, very important that we look at that stigmata of chronic liver disease. Macronutrient deficiencies as well. You do have several signs that you can see in the body, in the mouth, and so on. And we have to look for heart failure as well. You know that some of the macronutrients, the B3, can cause some alcohol, the wet belly as it is described. So we really need to manage these patients slightly better to reduce mortality. Next slide. So this is just the source. I'm going to share the slides, the bibliography, where you can read more if you are interested in some of these conditions. Next slide. Yeah, and I'll end here. Thank you. We'll pass it on to Dr. Delao.
Thank you very much for that interesting session. Picked out quite a number of issues, and I'd all hope that our network have managed to pick out something. We'll give you just 5 minutes for any burning question before we allow Prof to share his slides, and then he can also share a session. And then afterwards, we'll have Dr. Delao give a session. Any burning questions from the network?
Additions from Dr. Mwemba and Dr. Sankara.
Okay. So we also still want to allow our experts to give their comments and share. Dr. Mwemba, Dr. Sinkala, if you're on the call, please, you may add a few things that may have been left out. Okay, any questions? Prudence, I see you've unmuted yourself. You want to ask a question? Please remember to mute yourself when you join in. So Dr. Sibide, I think maybe people might be interested. We gave a poll question. What was the answer for the poll question?
Yeah, so it's all of the above. They are possible. That's why we are emphasizing that this phenotype of patients are quickly transferred where the diagnosis can be ascertained and probably managed better at a tertiary level where some laboratory capacities are present, because you might not know what is going on in that particular individuals. But with good management, the lives can be saved.
Thank you so much. Anthony Chocha, you can unmute yourself.
All right, thank you so much. Good afternoon, everyone. Well, it's just a quick one. I would like to learn, like, suppose in a situation where a patient is brought in and they're quite acute. So, like, how best can we stabilize them before you quickly refer them? I saw from the recommendation say that we need to transfer them as soon as possible. But obviously, we cannot transfer a patient when they're quite critical, and then they're brought in this state. So how can we manage them before we transfer them, just to stabilize them? Thank you. I submit.
Thank you so much, Anthony. A very important question.
Yeah, so that's a good question. So obviously, when there are several things that are critical, when you're assessing a patient, we follow the ABC in most of these patients. The airway, the breathing is fine. It's a circulatory issue. And we want to reemphasize as well, in the center at Levy, we are receiving patients in shock without a cannula from the CTCs in the periphery. Sorry, not Levy, at Heroes. Please, we know you don't transfer a patient who doesn't have a line. You don't transfer a patient who's in shock before you put in some fluids. And this should be the same rule for those who are picking patients in the community. We hope that those running ORIS giving points, rehydration points in there. So you see some guidance soon. We hope that you have capacity to put a line and start some points. The ambulances as well should have the line ability to do that. So the first thing is put that 2-liter fluid in that patient. We hope that thiamine will be available even at point. You can give a bolus of 100 of thiamine. If you know this individual, you have those signs of malnutrition and alcohol use, before you give your dextrose, if at all they're in hypoglycemia. Now, hypoglycemia will be very challenging in these patients to manage. Remember, the half-life of glucose is like 30 minutes. So once you give, you need to recheck within 30 minutes to make sure, because it's actually difficult to treat hypoglycemia, which will continue to recur again and again, as we saw in some of these patients. So those are some of the things that you can do. But I want to reemphasize on making sure that there is some circulatory correction. The fluid status is corrected before the patient is transferred. Thank you.
Thank you very much for that emphasis, Dr. Sibile. So in view of time, we have been joined by Professor Mlenga here, and he will just give some highlights on the use of antibiotics for treatment of cholera. Prof, we have a network here of about 716 connections, and we're all eager to hear from you on this particular topic. Thank you.
Thank you so much, Dr. Ziambo, and good afternoon, colleagues. And Dr. Sivile, that was a lovely, lovely oversight to give on cholera and also the complications that we are seeing. We thought that when we have this discussion of the comorbidities that are associated with cholera and what we have seen over the past 3 weeks, we also needed to touch base on the use of antibiotics for the treatment of cholera. And changing. I need from the outset just say that the mainstay of cholera treatment is hydration, and we need to emphasize that, because any other therapy outside hydration, if it's not combined with hydration, we may not achieve our goal of saving our lives. And this short presentation will just highlight how antibiotics can be used, but also highlight some of the controversies regarding the use of the antibiotics. Now, they've been used since 1964, the antibiotics for the treatment of cholera. And we also have some trials which I'll go through, randomized controlled trials, which have evaluated how the antibiotics have had an effect on output of stool and also the duration of diarrhea, but also the shedding of the bacteria as well. If you look at when you compare those individuals who are on IV fluids and antibiotics, compared to those who are on IV fluids alone, there is evidence that the stool output is reduced. There's also the duration of the diarrhea is also reduced. And also, when you look at what is the culture as well, the duration of positive bacterial culture is also reduced by various percentages. So there is evidence of the use of antibiotics. And I want to go to the next slide when we look at why use the antibiotics. Now, this is a Cochrane review where different trials have been reviewed over the use of antibiotics, and we're trying to use this to gather evidence on how we can, as a country and also as health workers, use the antibiotics rightly in our settings. So when you look at the evidence which is there from a number of trials, like 19 trials, when you compare the use of antibiotics, they really evidence that there is shortening of the duration of diarrhea by about a day and a half compared to those individuals who have no antibiotics or no treatment at all. And this is over 19 trials. Then also when you look at the antimicrobial therapy as well, the effect they have on the stool volume by 50%. Again, this is 18 trials, and the number of participants, more than 1,000 participants. And the evidence is moderate quality evidence, which is good evidence. Trial evidence suggesting moderate quality evidence is good evidence for us to rely on. Then when you look at the amount of rehydration fluids, it's also reduced. The amount that you use for rehydration is also reduced. And of course, this is in line with the fact that the volume of stool is reduced. So then also what someone is losing is also going to be reduced by 40%, and this is from 11 trials. And the mean duration of the fecal excretion, this is the shedding, is also reduced by almost 3 days, and this is across 12 trials. So this data is from trials, randomized controlled trials, and it's quite useful data to use. And when you look at the different antibiotics which were compared in this review, looked at tetracycline, and also doxycycline, which is a higher generation of the tetracyclines, also was compared separately in a number of trials. Then chloramphenicol, erythromycin, azithromycin, then quinolones as well, ciprofloxacin, and also Septrin are the antibiotics which have been compared. So when you look at the individuals who have used antibiotics versus those that have not used antibiotics, and here I'll just highlight the main features. So look at the diarrhea duration. For those that have used antibiotics, there is, yes, Dr. Ziambon, the 36.77 hours shorter, and the duration of the dehydration. Yes, you can see that those that have used antimicrobial drugs, there is a reduction in the duration of diarrhea. And this again is moderate evidence. Stool volume as well reduced by 7.3 liters for the adults compared to 13.5 for the placebo or no treatment. And hydration requirements as well by 8.4 liters compared to 14 liters when there is no hydration. Then when you look at the duration of pathogens which are secreted as well, you see that it's reduced by 2.74 days shorter. And this evidence is also moderate evidence as well. So again, this data supports the use of antimicrobials for cholera. Then when you look at the choice of drugs, when you're comparing azithromycin versus ciprofloxacin as well, you can see as well that in terms of the duration of diarrhea, azithromycin reduces the duration to 32.43 hours shorter compared to the duration which is going to be there when you look at the ciprofloxacin of 71.5 to 78 hours. And similarly, the stool volume, you see that the stool volume is also reduced 113 compared to 322 between azithromycin and also ciprofloxacin. Then again, bacteriological failure, less failures on azithromycin compared to what you get on the ciprofloxacin. I would say that the duration of diarrhea, that's why you have moderate evidence. There's low evidence, again, fewer studies as well when you look at the stool volume and also bacteriological failure as well. The next slide is where we are comparing azithromycin with erythromycin. I know erythromycin is one drug which we haven't utilized mostly for cholera, but it can be used, but it has more GI side effects compared to azithro and also to doxy and other tetracyclines. So again, here, when you look at azithromycin versus erythromycin, the stool duration, the diarrhea duration is 12 hours shorter compared to erythromycin as the control. Then also the stool volume is also lower as well. And when you look at bacteriological failure, slightly lower as well on azithromycin. I would again say the duration of stool and also the duration of diarrhea and the stool volume is moderate evidence data which we have. Then doxy. Doxy, when you compare to the tetracycline, which you use for 4 times daily for up to 4 days, you can use up to 5 days as well. And when you compare to doxy given as a single dose or given over 3 days as well, you see that there's just 2 hours shorter for tetracycline. Then also the stool volume almost similar, 2.9 liters. Then bacteriological failure, 31 per 1,000 when it's compared to doxy. So again, you see that here the data is showing that the two are similar, and this is moderate data. So you can go for a shorter duration, which you can just give us once, which is doxycycline, as a tetracycline to be used in this case. Then when you compare again the tetracycline, the one you give for 4 times daily for 3 days, and you compare to the quinolones, and in this case, either ciprofloxacin or norfloxacin, again, for tetracyclines, you see a 0.9 hours shorter duration. Then the corresponding volume as well reduced by 187, and bacteriological failure is similar between the two of them. So the next slide highlights now the ciprofloxacins, the same ones now with the doxy which we are using. You see again there are marginal differences in the duration of diarrhea of 4.64 hours longer. Stool volume as well, 149 compared to the cipro. Then this is low evidence data. Then when you use the duration of these antibiotics, for how long do you give short duration, you give a single dose, or you give a long duration? And this is largely for doxy and also for the quinolones as well. And you see that across giving low-grade data, there is not much difference, the relative effect, not much differences. So really what someone really need to consider is if there is not much difference in terms of which one is better between the two, then you'd rather give a single dose as opposed to a long course therapy. So we see that in treating cholera, there is room for antimicrobials to be used. They result in substantial improvements in both clinical and also microbiological outcomes. Then the severity, similar effects in those who are severely ill and also non-severely ill patients. And azithromycin and the tetracyclines, they seem to have more advantages compared to either azithromycin or the quinolones as well as ciprofloxacin and fluoxacin. How about the guidelines? Now, this is where you have a mix of data and how certain data is used depending on which guidelines. WHO follows more of the public health guidance, where only those with severe cases or those with severe dehydration are the ones where antibiotics are recommended. You know very well that Bangladesh is a country which has been largely fighting cholera for a long time. And they have an international center for diarrheal disease research in Bangladesh, the ICCDR, and they give guidelines. Then they do recommend the use of antibiotics for those who have severe and also for the moderate cases as well. For the moderate cases, as long as someone continues to pass large volumes of diarrheal stew during their treatment, then antibiotics may be indicated. Even if they just may have some dehydration, you don't have to have severe dehydration. The International Infectious Disease guidelines and also the CDC guidelines, they are similar to the ICDDR guidelines. They recommend the use of antibiotics for both severe and also or moderate dehydration. But again, the moderate dehydration, it's for those who have ongoing net fluid losses. So those who are still having to pass large volumes of stew and they have moderate dehydration, the use of antibiotics is recommended. But further, for the CDC IDSA guidelines, there is also recommendation for all pregnant women and all patients with comorbidities, those that have severe acute malnutrition, those that have HIV infection. There is recommendation to use antibiotics as well. And these are the recommended antibiotics: Doxy, which we are using as 300 a single dose for the adults and the children above 12 years, including the pregnant women; Azithro as an alternative; then Cipro, Cipro and erythromycin, and the similar drugs as well for children as well, dosed at those various amounts as well. When you look at the Zambian, this is the latest, the next slide, the latest we have in terms of the resistance and the sensitivity. You see that the tetracycline, which Doxy is, the blue is highlighting the sensitivity, and the yellow is those intermediate resistance, and the resistance is the, I don't know if it's pink. So you see from there that tetracycline, ciprofloxacin, is ideal in our setting, and this is up to January 2024, and this is just Lusaka, but the similar pattern has been observed as well across the country, those that have the sample swell from Copper Belt as well. Chloramphenicol, not ideal. See that you are going to find a lot of resistance. Then cotrimoxazole, which we have been using for many diseases, and ampicillin, there is high level resistance to that. Again, for the under 5, it's a similar picture which we see with tetracycline and ciprofloxacin and Azithro as well. And again, drugs to avoid would be cotrimoxazole, ampicillin, and you also have a high number of chloramphenicol resistance as well. That was for the under 5, and this is for the 5 to 14 years. Again, you see a similar picture where Doxy, Cipro are ideal, and you have to run away from cotrimoxazole and also ampicillin. Azithromycin, if available, can be used. And this is the 15 to 49 age group. Again, it's a similar picture, emphasizing the 2 key drugs here, tetracycline and also ciprofloxacin. When you look at, again, this is supposed to be 50 years and above, it's a similar picture with Cipro and also tetracycline. Now, one thing which many people in the infectious diseases experts are worried of is the resistance. Now, this has been reported, it has been demonstrated in endemic settings, but also in epidemic settings, such as ours, as you have seen. This can result from accumulation of mutations over time to the Vibrio cholerae. Then you can also have some genetic elements which are transferred across different bacteria, and these they confer the rapid spread of resistance. The major risk factors which we have for antimicrobial resistance is the widespread use of antibiotics, including the mass distribution for prophylaxis in those individuals who have no symptoms at all. We have unanswered questions. Still, we don't know much on how the antibiotics may affect secondary transmission. If you treat the index case in a house, how would it translate to infection for the other members of the household? There are some experts who think that if you treat a index case with antibiotics, then you are likely going to reduce the volume of stool, and as a result, you are going to reduce the transmission as well, and you're likely going to have less of the members of the household be infected as well. Then another factor is because most of these studies have been done in people who are undergoing aggressive rehydration, it's quite unethical for you to say, I'm going to withhold rehydration so that I can see if antibiotics alone are going to work, when there's so much evidence that the primary therapy which is needed is fluid replacement. So it's the data is very limited in those individuals who have not received adequate rehydration. So extrapolating to those individuals would be very difficult, and that's a limitation which is there. And when you look at the summary recommendations is the use of antibiotics in cholera-infected patients, those with severe dehydration, or those who have some dehydration and they continue still having diarrhea, which is uncontrolled, and they are losing fluids despite the rehydration. Then antibiotics should not be used as prophylaxis for cholera prevention. However, in certain institutional settings, they can be used. I remember this gentleman next to me one time went to, is it a refugee camp, Dr. Sivile?
Oh, it was a construction site, Professor.
Construction site, what did you do?
Professor, it's unethical. No, I mean, like it was I think during the previous epidemic, it was a closed community, Sino-Hydro, where there were like 6,000 people, I think 2018. It was a closed community and they had a proper source and so on. So we did mass prophylaxis, and I think we were successful in that intervention. So in closed settings where you can control everybody, I think where people are not moving, and you have proof that these people were having but also the source of water was the same point. So we could clearly trace that, and we could also trace the index patient. It was a fantastic epidemiological work with Dr. Nyambe from ZMPHI. It was a close community where a relative of one of the workers in the construction site came to visit, and he was the one that brought the Vibrio from Chirundu to Kafue Gorge. And we could trace that person where he started a bit of fishing, and so we could understand what was going on, and we did that intervention. Like you said, maybe a prison where but I think the most important thing is also that source of water, the source of the contamination, if it's identified, and you can do all that good epidemiological work. But obviously that should go along with other interventions. People have tried it, Prof, against recommendation in Northwestern Province, which actually caused a bad in Northern Province. Mpulungu, but they were doing it in open communities and the outcome wasn't that successful.
Great, thank you. And also in this current outbreak we have used it in the prison settings when we had those 18 cases as well. And so far we can say that we are able to, in fact, we started using it when there were just the initial 7 cases. And that has been possibly contributed with other measures to halting the progression of the cases in the prison settings. As he has said, I don't think it was unethical what you did. You had some scientific evidence. You can use that, but it has to be quite monitored. Otherwise, it's not a routine recommendation. You just go out and give every individual in Kanyama some prophylaxis. You give them doxy or zithro. Then we need to be guided largely by the antimicrobial susceptibility testing. This should inform the local drug choices. So for us, we are confident that doxy and also cipro are ideal choices looking at the susceptibility patterns as we have shown earlier. But also there are summary considerations which we put up, and these are very important. We do not need to overemphasize the antibiotic treatment of cholera at the expense of oral and also intravenous rehydration. Remember that especially, in fact, all these drugs, all these antibiotics, whether it's doxy, it's azithro, erythromycin, cipro, they all cause the GI side effects, and these have to be carefully monitored for, especially in these individuals who also have a similar GI symptoms as well. And above all, we need to have prospective surveillance for antibiotic resistance. Among those isolates that we have, those that are isolating the Vibrio cholera, we need to have these prospective surveillance done as well. I'm glad that soon we're going to have data of a PCR for us to understand more on the patterns that we have. And our goal is not to have antibiotic resistance created in our population. So really, there is room for use of antibiotics, generally for those that have severe dehydration, but you can use in those other populations where you have moderate or some dehydration. You can give the antibiotics, and the antibiotics of choice are the ones which are guided by the antibiotic resistance. Thank you so much.
Thank you so much, Prof. Very important there. Mainstay of treatment, hydration, hydration, hydration. Of course, antibiotics play a role in managing cholera. So I know an excellent presentation. We'll always have some clarifications to make. So we'll just give an opportunity to those that have a question. For now, when Prof is with us, he just received the call and he will need to run off to attend to some other issues, but just a few more minutes for some questions. Meleki, you've raised your hand. You can unmute yourself. Then after that, then we have Jacob Ngambi also ask a question.
Thank you so much. Good afternoon, everyone, and good afternoon, Professor, and to the panel. That was a very informative presentation, Professor. I have a question, or maybe there's a presentation on supportive therapy other than microbial therapy. So my question is concerning supportive therapy. So generally, there's an emerging tendency for, especially in under 5 or pediatric cases, for mothers to initiate supportive therapy, which is ranging from, yogurt, activated charcoal, and things of that nature. Do you have any comments on these supportive therapies, which are being initiated prior to?
Very interesting. Thank you so much for those questions. Before we respond, we'll ask Edward, is it Jacob Ngambi, to make a comment, and I'll ask the pediatricians to get ready to respond to those questions. I'm looking at Dr. Chimikapiri. Yes, Jacob? Hello, Dr. Jacob. Is that you? We can't hear you. You've unmuted, but we can't hear you. So we can't hear Jacob. I'll skip and ask Alipilas Chiwaya to unmute and ask a question. IT, are you able to help us with that volume thing? Either it's here or we can't hear them.
Hi, Dr. Kozia. We are okay from our end. I suspect it's from their end.
Okay, I can hear you as well. Thank you. Hezron, are you able to unmute and speak?
Yes, good afternoon. Thank you for the presentation. I don't know if I might have missed the part where you were talking about HIV patients who are positive and also having cholera. My main area of interest are for the pregnant women who are HIV positive and have cholera at the same time. I don't know if you've already passed that area already, but if not, what's the best approach? Number one, in line with stabilizing them as they come through the facilities, and also on the part of antibiotic utilization or prescriptions in the area of management for these women, as well as the children younger than 5 years who are HIV exposed. As you might be aware, these are children that are already, especially those that are less than 2 years, these are children that are already on a prophylaxis of Septrin for a certain period of time. So in that event of them now having this cholera infection diagnosed amongst them, what's the best approach in terms of management? Thank you.
Thank you very much, Hezron. We can take one more question from Edward Daka. Edward Daka, you may unmute yourself.
Are you able to hear me?
Now we can hear you, Dr. Jacob.
Thank you so much. Good afternoon, Prof. Good afternoon, Dr. Seve. My question is for my friend who owns a nursing school. They're having students who are coming from the hotspots from Lusaka. So where they are, there's no cholera. So they're asking, instead of the prophylaxis, because I discouraged them using antibiotics. So the question is, how long can they isolate their students while they come for school? Thank you. Submit, Chair.
A closed setting, hey. Thank you, Doc. Maybe we can have some responses just quickly to those questions. The first one was about the so-called supportive therapy around activated charcoal and yogurt. And then maybe Dr. Chimika, you can respond to this one.
Okay, thank you and good afternoon, network. Thank you, Dr. I think this came from Dr. Meleki.
Yes, Dr. Meleki.
Yeah, so I'll answer for the pediatrics patients. I know that the presentation focused much in terms of the treatment vis-a-vis the rehydration as well as the use of antibiotics. But remember that the third area where we need to pay particular attention, which we need not to forget, is in nutrition. Because especially for children, if we don't address the issue of nutrition, they'll die from hypoglycemia. And I think we saw this at Heroes, where we did well in terms of rehydrating and also swallowing the antibiotics. But in terms of taking care of nutrition, is very crucial. So I'm not sure about the use of activated charcoal, Dr. Kozia. I'm not sure where this is coming from, but I can comment on the use of
sour milk. I think she mentioned about sour and all of that. Yeah, yogurt. Yeah. So, yeah, I know this may be coming from the evidence in terms of enteritis. We know that usually, especially in children, acute enteritis, there's derangement in terms of the enzymes. So we usually look at what available food that they can tolerate well, and usually we look at the fermented products. So the most available one would be a sour milk, or those that can afford yogurt. And this is why we usually recommend that they take that, because of course, even the nutritional value is good for that. But we really need to take care of the nutritional part of it. In addition, I think the other support, these are patients, so it's upon the clinician to assess if someone is acidotic or someone who needs oxygen. I think those things may not have been mentioned, but they are part of care for these patients. Dr. B.
Thank you so much. I don't think there's anywhere, any studies that have demonstrated and shown the role of activated charcoal in management of cholera in children. And I think those therapies are not something that would recommend. But I think a nutritional supportive therapy is very critical in children to manage your hypoglycemias, manage the anemias, the micronutrient deficiencies, and all those things. I think there is actually a pediatric presentation where we address nutritional support. I will be able to share those slides with you for your information. Then the other questions, Prof.
Yeah, so everyone was asking of the HIV-infected people and the pregnant women, and also children, larger children as well. How would we use the antibiotics? Yes, now, I think tetracyclines, especially in children, there was an issue of dental enamel hypoplasia and the staining as well. But recent data has shown that there's little or no staining and also the hypoplasia. So these can be safely used. And again, you know, these are high-risk populations, HIV-infected people, and that's why you need to use these antibiotics as recommended in them. In fact, even in this current outbreak, we have a number of patients that for HIV infected, we need to screen for other infections as well. It's possible someone may not just be suffering from cholera. Mpanga is online here. They will be able to see to tell you that we have seen a number of pathogens as well. I think Dr. Sibile even saw Ascaris. You saw it?
Yes, it's plenty. So we are joining everybody in the center. Yeah.
So these who are at high risk, they need to be treated comprehensively, and that's why for these high risk groups, if you've seen those who are pregnant in Lusaka, HIV infected, we are largely pushing these with comorbidities to Levy, where they can be managed appropriately and where more investigations can be done. So yes, the drugs which are there are safe for these populations and for both pregnant and also the HIV infected. So Hezron, we recommend that they are used.
A comment on nursing schools?
Nursing schools, and this is the first time I'm hearing of quarantine or isolation before. Now, as you know, within 24, 48 hours, for 48 hours largely, the symptoms should be able to develop in someone who's been exposed. But again, you need to know that shedding may also continue even if someone has no symptoms at all. So it's a very difficult, I think, intervention for you to say that we need to quarantine someone or isolate someone for us to know if they have cholera or not. And again, only 10% of individuals who are exposed are going to develop symptoms. So you still have these 90% who may even be shedding and may also be a source of exposure. So we are not recommending from the ministry any isolation of someone who's coming from an infected area before they start mixing with other people. Thank you.
So just to add, Prof, I think we emphasized in the first presentation, Dr. Ngambi, that cholera is not human-to-human transmissions are quite rare, even in case reports. So even me sharing the office with Dr. Ziambo, and if I've got unlikely that I'll give him because of the way of transmission. So that should be very, very clear. I think we received that request, Prof, if you remember, even from Manasoko, where there was somebody who had cholera and discharged, but the household were refusing to take that person back and asking for so there are these so a lot of questions that are coming, but we are not recommending quarantine, isolation, or those who are deemed to be coming from exposed area to be given antibiotics for clearing or whatever you'd like to call it. All those recommendations are not there because the mode of transmission is exposure to contaminated food or water. If you like, maybe that individual should not be allowed to maybe cook or prepare the food, that sort of thing, but they will not transmit the disease or the organisms to another individual, even when you are in the same home. So human-to-human transmission is very rare.
Thank you so much. Prof, before you leave, I think just a comment on the oral cholera vaccine. There's some questions here. My question is in terms of OVC, which have been distributed in Lusaka. Are they also being distributed in other provinces like Mchinga? Because the general populace have this notion, we have taken, obviously, we are now fine. It's the same question here regarding vaccine. What's the plan on how can we give an according without waiting for outbreak? Do we give OVC without waiting for an outbreak? I think it's just some knowledge around the oral cholera vaccine. Just your comment, then we can move on to the next presentation. Dr. Dalao, please prepare yourself and share your slides.
So yes, so the vaccines for now are going to be limited to the areas which are hotspots. And in Lusaka, there are 5. It's Kanyama, Matero, we have Matero George, then we also have Chawama, and we also have added Chilanga, then Chongwe is also another, and also Funsa. We have received 1.7 million doses. As of today, if I remember well, we've done 1.2 million, and we are still looking for more doses to be distributed. It's not going to be given to every Zambian. It's only those who are in areas which we think are hotspots. We are not, of course, supposed to wait for cholera. We're supposed to vaccinate in the hotspot areas, and we know these hotspot areas. So it's not every person who is going to get the vaccines, and it's only in these hotspot areas. Even if we had plenty of them, if there was no limitation, it wouldn't be recommended to give to the hotspots. However, for the healthcare workers, which largely most of you are those who are working in the treatment centers, we have vaccines available, and we are recommending if someone feels that they need to have some protection, they need to have access to those vaccines. They are being given in the various treatment centers for the workers to avoid them getting any severe forms of this disease. There's room for Dr. Chipimo. You need to highlight that.
Hi, Prof, and hi, everyone. Good afternoon. So I was just adding to what you said, Prof, that there are several vaccination strategies that are used. You can have whole community vaccinations, you can have ring vaccinations, you can also have preemptive vaccinations. So preemptive vaccination is a strategy where you can actually give a vaccine, for example, OCV, to a population that you know is prone, or an area that is prone to cholera, even in a situation where you do not have any cases reported. But like you rightly pointed out, Prof, the limiting factor is the number of cholera vaccines that we have. You will even see that with this campaign, we are only giving 1 dose, and that is, of course, not very optimal. But this is basically because we don't have enough. So in as much as, yes, there is room with enough justification to vaccinate even without an outbreak, we tend not to do it. And one of the major reasons is vaccine availability. Over.
Thank you so much, Dr. Chipimo. That is important, and that's the strategy which we are following. Remember, we've been emphasizing over the past 1 year plus that we have a lack of availability of these vaccines. And again, thanks to WHO, Gavi, through UN systems for affording us this chance of having these 1.7 million vaccines. Thank you.
So thank you very much. Very interesting questions, and I know they keep coming up. So just so that we don't stay here for a long time, we will allow Dr. Delau to just speak to alcohol withdrawal syndrome, delirium tremens. And Dr. Delau, please do go ahead and introduce yourself and give the talk. Professor, thank you for coming. We appreciate your presence. Please, you may proceed to other national duties.
Thank you.
Thank you, Dr. Kozia. Good afternoon, everyone. My name is Dr. Naim Dalal. I am a mental health specialist and currently with the Zambia National Public Health Institute as the NCD's Injuries and Mental Health focal person. So this afternoon, I'll be continuing on what Prof. as well as Dr. Sivili have spoken to, in particular, a particular population that we are reviewing in our cholera centers. And this has to do with alcohol use. In particular, we will be talking about delirium tremens, which is the most severe form of alcohol withdrawal. So the objectives overall is really to answer this question, which is popping up in many of the communities, even on social media. Does Kachasu cure cholera? By the end of this, we should be able to understand how to support patients with alcohol use and in cholera, but of course, keeping in mind all the various concepts and backgrounds that Dr. Sivili has highlighted. So we also want to guide you on the use of benzodiazepines because oftentimes as healthcare workers, we become very excited and use diazepam to support alcohol withdrawal. But in this case, we have to be extra cautious in understanding what is it that we are triggering in our patients. We also need to understand the risk as well as the benefits that we are doing in terms of our treatment. Dr. Sivili has highlighted thiamines, the use of it. Dr. Sivili has highlighted the use of glucose and how it can be lethal, but at the same time, it can be useful. So how do you use that? And also understanding the complexity of measuring improvement, because it's all about clinical acumen, having that correct understanding concerning mental health. So the layout is very simple. We'll be talking about the syndrome itself, which is a collection of symptoms. We'll be talking about DTs, the most severe form. We'll be talking about what is it that you'll be doing in assessment. There was a question about referral. When do you refer? So we'll also be discussing that. And also the treatment algorithm that we are currently using at the CTCs in Lusaka province, but in the treatment guidelines that we'll be sharing at national level, for you to understand that what is it that you need to keep in the back of your mind if you indeed have alcohol use. So overall, alcohol withdrawal syndrome is a clinical syndrome, and it is going to happen in people who are physically dependent on alcohol, who suddenly stop drinking or reduce their alcohol consumption. And because they have reached the dependence level where without that particular amount of alcohol in their system, they won't be able to function as their body usually does because the brain has become used to it. So these are individuals that will end up with what we call alcohol withdrawal syndrome. Now, it is divided into 4 categories. We have minor withdrawal, we have major withdrawal, then in between there, we have withdrawal seizures that occur, and then we also have what we call DTs, which I will be referring to throughout this presentation, known as delirium tremens. So everywhere you see DTs, we're talking about delirium tremens. So let's talk about the timeline. Here's a patient that's coming with cholera who's dehydrated, but then is coming from a community where there's a lot of alcohol use. So that should be your first suspicion to say these are individuals coming from a place where a lot of alcohol is being used. So there is a high likelihood that these individuals are going to end up with alcohol withdrawal. Of note, in Lusaka province, most of our highly densely populated communities, Matero, Kanyama, George, we have the leading cause of admission is alcohol use disorders. So already you need to have a high index of suspicion to say we are likely going to get alcohol withdrawal in our patients, wherever these patients are coming from, especially in Lusaka province, Copper Belt as well as parts of capital cities in the whole country, Choma, Chipata. We have to have that index of suspicion. So you need to understand also we are playing with time here. Colleagues, we are talking about timelines where we are talking about hours, not even days. Here on the top of the slide, you see day 1 to 3. That is where we are when we're talking about alcohol withdrawal. But it's all about time. So even when we are talking about referral, you really need to document timelines. So there's 6 to 24 hours, which is day 1. Then we're going to go from up to 48 hours, and then we're going to go to day 3 to 10. So there's minor withdrawal, where it's going to happen in 6 to 24 hours. Then we have major withdrawal. Alcoholic hallucinosis comes in. This is where mental health and psychosocial symptoms will come in, such as visual and auditory hallucinations. According to our anecdotal findings, as well as at our clinical practice here in Zambia, most of our hallucinations have to do with tactile, where our patients often think that there are insects crawling on them, or they often visually hallucinate. They think they see cats or snakes. So these are the hallucinations that you're often going to see, observe. Then we have withdrawal seizures that often happen 6 to 48 hours of alcohol cessation. So these seizures are very specific. You are going to be generally very short and generalized in nature. Okay, the seizures last for not more than 2 minutes in average. They'll be less than 60 seconds or less, and they'll last they'll be generalized in nature. Also, you need to understand that more than 60% of patients with alcohol withdrawal will actually have withdrawal seizures. And also, it is the first sign of alcohol withdrawal. So when you start seeing seizures, of course, you need to rule out other things, but if they're coming from a community where alcohol use is prevalent, you need to start thinking, okay, we may be thinking of alcohol withdrawal in this case. Then, of course, we come to the medical emergency, which is delirium tremens, DTs, where in 3 out of 10 patients who have alcohol use, they are likely to be tipped into delirium tremens. And this is what we are seeing in our response so far. It is the most severe manifestation of alcohol withdrawal syndrome. It occurs after 2 days, so 3 to 10 days following the last drink. And this is where what we call global confusion happens. So colleagues, here we're talking about this is a person who's not going to be oriented in any domain of their life or their reality. They're going to not know where they are. They won't know who they are. They won't know what they are doing or what is happening, which is compounded by the hallucinations that we speak of. So in addition to that, you are also going to have the autonomic arousal, which Dr. Sivile already spoke about, because homeostasis, the body's ability to control itself, is also thrown off. So you're going to see all these different symptoms happening all together at the same time. So this is where you have delirium tremens. So colleagues, this is the timeline. So again, we are working with time here. So we really need to start thinking to say, if a person comes in with tremor, anxiety, nausea, vomiting, and insomnia, inability to sleep, then you need to already know that you're already in minor withdrawal. And this person possibly took their last drink more than 24 hours ago. So just to give you this slide for you to have a better understanding. So this is going to be in the guidelines that we share. Now coming to delirium tremens, again, it's the most severe form of alcohol withdrawal. We have altered mental state, global confusion. What we mean by that is they are not oriented to time, place, or person. And also, the global confusion is not just in person, in reality, but also the confusion is happening in the homeostasis, in the body's ability to control itself. It is completely thrown off, okay? Metabolism, everything is totally confused in the body as well. So what Dr. Sivile mentioned in all his concepts is what's also equally taking place. We also have sympathetic overdrive, and also it can progress to cardiovascular collapse. And as Dr. Sivile's case guided, there was actually a arrhythmia, and then the cardiac complication took place. So this is what happens. So now, I'm sharing with you the assessment for alcohol, which is a clinical instrument. When we are talking about global confusion, this revised clinical alcohol withdrawal assessment tool actually takes you through all the various signs and symptoms that a particular person is going to experience. So if you really want to observe, and if you really want to assess a patient who has a high prevalence use of alcohol and they're coming in with those symptoms, then you want to quickly constitute and apply this particular assessment. It will help you cover all the various signs and symptoms that delirium tremens can present with the phenomenon of global confusion being on top. So due to time, I won't go into detail, but just to give you an understanding that this is a score that can get you over 67 points, and it will guide you whether this person is in mild, moderate, or severe, which is delirium tremens. So in physical examination, I know we have a lot of officers who have joined us who are working nationally at various CTCs. You won't find any specific findings on physical examination. However, you need to understand that in DTs, individuals with delirium tremens often have coexisting comorbidities, illnesses. And this is where Dr. Sevilla's communication and presentation comes in, where you really need to fully observe and you really need to understand clinically what this person is presenting with. Of course, because these are individuals who are using alcohol, they may have poor hygiene or may also have certain signs and symptoms of trauma. You also need to look for any bruises or cuts, because that can be an easy entry for sepsis to come in. So you need to understand all of these points and you need to physically examine for all this and understand and document. Now, complications of delirium tremens. If we don't manage delirium tremens on the third day when it onsets and we don't give it that timeline, we are going to end up with cardiac arrhythmias. We may also end up with oversedation, and this may be because of the various treatment protocols we start, especially the diazepams that we start introducing to the patient. But also we need to understand that when these individuals are in global confusion, even their respiratory center in the brain is affected, and they often have respiratory depression, but also lead to these complications. And of course, you need to monitor and nurse these individuals in a certain position, because there's also risk of aspiration pneumonitis, which these individuals come in with. Not forgetting, these are patients who are coming in with cholera. They do have wrenching and they also vomit. So when you are treating comorbidly for alcohol withdrawal, you really need to take into account all of these factors, which may lead to death. And this is what we are recording as mortalities due to these oversights that we have. Now, of note, we also need to understand that it's very, very key for us to rule out other concerns. Of course, delirium tremens will throw this person into all these electrolyte imbalances, but also we need to understand that in patients who are using alcohol, there is a comorbidity risk of syphilis as well as HIV, which can also lead to symptoms of hallucination. So we also need to understand these points, colleagues, because this is what's going to guide whether we give just the treatment for DTs or we also introduce other medications, because there is no role for antipsychotics or anti-epileptics unless otherwise in delirium tremens. So understanding workup laboratory investigations, this is why the guide is immediately document, assess, do your ABCs and refer to a tertiary center so that all of this can be done. However, if you observe that this person is severely dehydrated and they are actually in global confusion, then you have to start your resuscitation right then and then and not wait for that referral to take place, because it's a game of time and mortality can happen even during transit. So you need to look at your electrolytes, and the common things are common, hence the ones that have been highlighted and put in bold here. Treatment. Now, this is what we've been seeing so far, especially in Lusaka province and the consultations that we're doing through other provinces. Approach considerations. We're having challenges where there's failure to consider the diagnosis of alcohol withdrawal syndrome in patients with altered mental status. Unfortunately, many of us are unable to pick this up quickly because of time. Again, it's very important we pick it up quickly. Failure to treat patients with severe alcohol withdrawal syndrome with adequate doses of benzodiazepines. Again, we are just shooting in the dark. We're not really understanding how the diazepines work in this global confusion state together with possible comorbidities. So we really need to understand the dose and the route of diazepam or benzodiazepines that we are giving. We are also making a lot of assumptions that all seizures in people that come in with alcohol use are due to alcohol withdrawal. Okay, so we also need to understand there may be other causes, because at Heroes, we had one particular case where it wasn't even alcohol that was leading to the seizures. It was actually a CNS or eye that was causing central nervous system opportunities infection due to poorly controlled HIV. So we need to make sure that we have this high clinical understanding and acumen. Failure to exclude other etiologies, other comorbidities that Dr. Sivile has highlighted so far. I won't go into that. Failure to admit patients to the hospital with signs and symptoms of major withdrawal. Again, we are seeing some patients in the communities, and then we are not admitting them thinking that they will be fine as outpatient. We are also failure to diagnose such conditions as hypoglycemia and pancreatitis, as highlighted by Dr. Sivile. Failure to administer thiamine in patients presenting with alcohol withdrawal. Again, the understanding is that we should have prepared and have thiamine in our CTCs because it's very key, not just for the malnutrition that adults may present with, but also because of the alcohol, and failure to use adequate clinical sedation with use of physical restraint. So also, this is another thing. When an individual is globally confused, I'm not talking about just mentally, but also just generally, you need to have proper understanding of how to restrain, not just tying individuals tightly with the bed. That is inhumane, especially in 2024, and with our Mental Health Act now. So we need to understand how to physically restrain. So we need to understand that these are the failures that we have seen in our response so far. So we need to improve on this. I won't go into detail on this slide, as I want to go and guide you on actual treatment. So let's talk about thiamine. Thiamine on its own in delirium tremens, in alcohol withdrawal syndrome, has no effect on the symptoms or signs, on the incidence of seizures in particular. However, it does support with the UNE and micronutrient deficiencies that it actually causes. So people have this notion that thiamine will help with seizures, but that's not today. That's not true. It's also important that we give thiamine because it prevents what we call Wernicke's encephalopathy, which is a global state of another confusion that ends up with confusion, ataxia, difficulty in change in gait in walking, and also eye ophthalmoplegia. So you need to understand that we give thiamine prophylactically in alcohol use withdrawal syndrome so that we prevent Wernicke's. Also Korsakoff's, which is amnesia that happens immediately, especially in patients who use alcohol for a long period of time, or in patients that use heavy alcohol, such as cachasu, as well as spirits to jili-jilis, etc., in the communities that end up having Korsakoff's right in our admission. So it's very important for us to understand. Now, again, the questions are there, as Dr. Sivile has highlighted. What dose should we give? We have to give at least a minimum low dose of 100 milligrams, or we can go as high as 250 milligrams, okay? Once daily if we are dealing with alcohol. Now, again, on this slide, it's just talking about people with severe alcohol withdrawal, people with poor diet and signs of malnutrition. Thiamine should be administered intramuscularly in higher doses of 2 milligrams or more, up to 5 milligrams for 3 to 5 consecutive days. Again, this is to support with prevention of Wernicke's in alcohol use, but also the micronutrient deficiencies as highlighted in Dr. Sivile's presentation. Again, monitoring glucose. The questions are there because glucose itself, as Dr. Sivile has highlighted, can cause a lot of challenges. However, when giving glucose, make sure you have administered your thiamine before glucose because of the metabolism of thiamine, which uses up glucose. You are going to tip individuals in, if you give glucose, then thiamine, you may tip individuals into hypoglycemia, and that may lead to immortality. So you need to understand thiamine before glucose. But also, you also need to understand that we don't give boluses of glucose because of the complications that it can predispose. So we give it in dextrose solution. So again, that is a communication that is very highly recommended. However, if you have a person that has if you have a low glucose, you have hypoglycemia, random blood sugars of less than 4.3, then please do give a bolus, which has been highlighted here to say 10 pills or 50% dextrose can be given in that situation, making sure you are monitoring every so often in that resource. So once you have done with your glucose, you need to maintain these individuals on dextrose solution for a 24-hour period, and you have to constantly monitor your random blood sugar because hypoglycemia is a complication. Again, diazepam, which you will be using for delirium tremens, also uses up glucose in its metabolism, so you are going to further tip into hypoglycemia. So maintenance glucose is a must. So you have to monitor and maintain glucose in 24 hours and monitor glucose level at least every 4 to 6 hourly. And you have to document, colleagues. This is a problem that we have. If you're not going to document, we are not going to know what complications and what challenges we are having, because these are key elements in treatment. Then again, when coming to diazepam, we are very excited that, oh, we have diazepam, let's just sedate. This is a problem case, let's just sedate. No. You are tipping a lot of people into a lot of complications, and mortalities are happening because of treatment gaps that we have. We are using, in cholera cases, we are not just using the standard fixed dose regimen of, oh, this is alcohol withdrawal, so let's start 10 milligrams or 20 milligrams TDS 4 QID 4 times a day. Day 2, let's titrate down to 3 times a day, 2 times a day. No, we don't do that in cholera. Cholera already has electrolyte imbalance. It already has fluid imbalance. It already has a lot of metabolic challenges. Then you are coming in and you're giving diazepam, trying to create a lot more confusion in this person's body and homeostasis. So what we use is symptom-triggered benzodiazepine, which is usually we use very high bolus and then we go down. So it has to do with your observation and your clinical acumen. This is why we are guiding to say, once you start treatment with diazepam, make sure for at least a minimum of 12 hours, it's the same clinician that is observing this patient, because it has to be a clinical acumen that comes from that particular individual. If we keep changing staff, it's becoming very difficult for people to monitor and observe how the response is. So with benzodiazepines, again, the recommendation and the standard is that we give IV diazepam. You have to have IV access. Don't give diazepam IM. Why? Because intramuscular administration of diazepam leads to variable drug absorption. Diazepam tends to accumulate in the lipid layer in the body, and it seeps out slowly after that. This is why we need to make sure we give IV so that uptake is quick and the long half-life takes its root. So it is important to have an IV access, and this is something that I will guide all of us here to make sure we do that. Oral formulations, for oral medication, diazepam is only given if the person is oriented to person and is able to take oral feeds and is not vomiting. So benzodiazepine choice, as of now, we are using diazepam as it has a longer half-life, and we are starting with a loading dose of 10 milligrams. Unless otherwise, we give 20 milligrams. We observe, we monitor for 30 minutes to 2 hours, and then we load again, another 10 milligrams. By then, if we see there's no improvement, colleagues, document and refer to a tertiary space so that we can take it up from there. However, if you see after 10 milligrams or another 10 milligrams in 2 hours, 20 milligrams in 2 hours, and there is an improvement, then of course you can continue, as you don't need to send every patient forward. So titrate the diazepam dose based on the patient's response. The tool that was shared earlier is what we use. Is the improvement in the assessment, because that will guide us. So we maintain 10 milligram IV QID for the first day, and then we are going down to 10 milligram IV 3 times a day on the second day, and then we're titrating down to 10 milligram IV morning and 20 milligram IV on the third day. By this time, if there are no comorbidities and complications other than just alcohol withdrawal, the patient will improve, and this is what we are seeing at Heroes as well. However, by the time the first 24 hours are moving and you have followed this regimen and there's no improvement, colleagues, document and refer to the next point or consult with a specialist so that you can be guided. You need to monitor your vitals, sedation levels, which is your Glasgow coma state, as well as the scores regularly. It's very important. Then coming to the maintenance dose of benzodiazepines, let's say you've reached your third day, you need to maintain 5 to 10 milligrams every 4 to 6 hours. So 5 milligrams TDS 3 times a day or 10 milligrams 3 times a day. That is what you can prescribe as per oral. And this is again symptom triggered. And then what you do is, if at this point after 3 days they have improvement in their scores, they will have dropped from delirium tremens, which is severe, to mild. Then if the signs and symptoms of cholera hydration have also improved and they're able to take oral fluids, then we are discharging. At this point, the person is to be discharged and not kept in the treatment center, because they have stabilized and we discharge and treat from the communities where they're coming from. One other thing that we also need to monitor, which Dr. Sivile highlighted, but to take you in addition, we have seen mortalities because of hypothermia in alcohol withdrawal syndrome. Remember, there's global confusion. The whole homeostasis, body's ability to control itself is off. So with alcohol withdrawal, patients are unable, individuals are unable to, the brain is unable to control the temperature, internal temperature. So you have to monitor temperature levels as well, and you have to control that. In the CTCs, we have seen that the blankets get very wet, and these individuals are in an open space. We really need to monitor temperature and also maintain that homeostatic environment for the body temperature, because hypothermia also leads to metabolic challenges and death. In addition to that, there's fluids which have already been highlighted here. Fluids have to be considered according to the cholera management as highlighted. However, follow a plan for patients with alcohol withdrawal. Say you've reached day 3 and they're on oral diazepam, then colleagues, you need to discharge, send them back to their communities. And in that communities, make sure on the discharge, you have communicated that they are reviewed by the mental health unit at community level. And if there is no mental health unit, then make sure the physicians continue supporting this particular patient, because there is no way we are going to be giving psychosocial counseling at the point of discharge. Individuals have gone through a lot of traumatic experiences and they are unable to grasp all that psychosocial support at that point. So you need to identify next of kin and take them back to their homes, and from there continue with their support. Now, referral criteria already Dr. Sivile has highlighted. However, I'm going to mention this. If you want to refer, please make sure you have recorded what you've done. Do your resuscitation, do your ABCs, make sure you've started what you have to start. If you've started diazepam, make sure you maintain and you monitor what you've written and you tell us what started. Because when we come here, we also need to know what timelines we're talking about. With alcohol withdrawal syndrome, especially with delirium tremens, it's a game of time that we're working with. Also, we don't want to oversedate and cause unnecessary complications. So please make sure detailed record keeping is key of all that has been mentioned, but also patient tracker. We have had situations where people are just referring cases. They don't know who this person is. They don't know which sub-district they're coming from, and we don't know what the next of kin information is. That is also very key for alcohol withdrawal syndrome, because it actually helps us. If there are comorbidities such as syphilis, HIV, we are able to trace that quickly and support treatment accordingly. So please refer and put information of next of kin and also information around supportive care. I won't go into why you need to refer. If in 24 hours you've started your treatment algorithm and there's no improvement, don't wait. In fact, 6 to 24 hours, there's no improvement. You've started your thiamine, glucose, DZ, there's no improvement in 6 hours. You've monitored every 30 minutes, 2 hourly, then refer. Now, supportive therapy for alcohol withdrawal syndrome. In summary, this is where we are. You have to continuously assess. You need to make sure that there are no comorbidities. You need to make sure that, you know, if you want, of course, in alcohol withdrawal, they haven't really shown any studies. There's no evidence that shows that other than thiamine, other vitamins can have any effect. This is why for us, delirium tremens, alcohol withdrawal, our gold standard vitamin is thiamine. Administer IV. Make sure you have your fluids and you have your diazepam. Also, make sure for glucose, you're not just giving boluses unless there's hypoglycemia or glucose is less than 5 on the RBS, but make sure it's in a solution form. Aspiration pneumonia is very common because they tend to regurg and they tend to also have that challenge. So make sure you are nursing in accordingly, and also monitor your electrolytes, because that can also lead to complications. This is where I end, Dr. Kozia, but I would like to mention this. Refrain from utilizing terms such as problem patient, problem case, difficult patient, alcoholic, or Chinama case. Colleagues, we are in 2024. Let's support and employ more clinically appropriate terms such as substance use patient, alcohol user, person with delirium tremens, alcohol, or patient with alcohol withdrawal syndrome. So I will stop here, and thank you very much. Because, yeah, we can't hear you.
Oh, yeah. Can you hear me now?
Yes, we can hear you now.
Oh, thank you very much. I was just saying that thank you for the helping us upgrade our language from those derogatory terms. And so we appreciate, and it's very important for that. So we'll now invite any questions from our network. If we have any questions we'd like to ask regarding this very interesting presentation we have today, and see if how our panel of experts can respond to those questions. Any questions? I've seen lots of email addresses that have been posted. We do hope that we'll be able to capture these and send the email, but kindly note that this session, all the slides are usually shared on SlideShare, and then also this session is recorded and it will be posted to YouTube, the MOH Echo YouTube. So I've seen a hand. Leonard, please unmute yourself and ask a question. Leonard Margaret.
Yes, good afternoon.
Afternoon, thank you.
Yes. My question goes to the presenter. The doctor was just been presenting on withdrawal syndrome.
Sure.
On the basis of researchers, and you admit a patient with signs of severe alcohol withdrawal syndrome. Does alcohol at that moment has any role, administration of alcohol, to push back the patient into stability, and then you start counseling to withdraw slowly? Has any role? Thank you.
Leonard, I like your question. Dr. Dalal, there's something thrown at you. Are you able to respond to that?
So studies have shown, a lot of literature has been done on this actually, Leonard, and it has been found that the metabolism of alcohol itself, the general alcohol that we use, is not conducive to our liver. And this is why in withdrawal, if you're going to give them alcohol at that point where they are going into delirium tremens, it is not going to be as effective as our treatment with benzodiazepines, which is titrated, because of the mechanism of action of the benzodiazepines that we use versus the actual alcohol. By the time a person is in delirium tremens, they actually go into a state of overdrive, and the usual alcohol they use is not effective. So a lot of clinical trials have actually been done, and this is the teaching. And please refrain from, and I've seen this happen in a lot of communities, especially in far-reach areas, in rural areas where we don't have diazepam, and people have tried that, but it doesn't work. So research-wise, it has not worked. In addition to that, Dr. Kozia, there was actually a question on thiamine in the chat before all the emails. There's one question asking, how do you administer, in what fluid do you administer thiamine? So thiamine is actually oral based or fluid. It actually comes in fluid form. It's a vial, injectable vial. So we actually give it as a slow IV push, 100 milligrams parental. So it's a slow IV push that we often give. And then orally, we just give it orally. It also comes in tablets of 100 milligrams, or there are also 50 milligrams that. So how long do you give it? So in admission, as I said, the maximum you can go for alcohol withdrawal is you can go as high as 250 milligrams BD. So that's 500 milligrams in a day. However, you can also use your observation and guide, but maximum we guide is 250 milligrams twice a day. And then you maintain that for at least 3 to 5 days. And then when a person is able to take orally, then you can maintain them either on 100 milligrams once a day, or 100 milligrams twice a day orally. And for how long? This one is where we actually say, if it's a chronic alcohol user where it's a person that is using alcohol, then we actually ask to have them introduced to a mental health unit so that they can be followed up from there for further support. But we in alcohol withdrawal syndrome prescribe it for at least a minimum of 14 days as outpatient so that they can be supported with that. Over.
Thank you so much. Hope that was very helpful to you, Leonard. Any other questions from the network? We have we had requested to do this session up until 16:30, so we only have a few more minutes remaining. Any other questions, concerns? Clavius, go ahead and unmute and your comment.
Good afternoon.
Afternoon, thank you.
So I just want to some clarity from the doc.
Sure.
The clarity is I'm arrived to the fact that some clinicians, when we have a patient who is in alcohol withdrawal and they do not have diazepam or the benzodiazepines, they opt to use promethazine, phenobarbital as sedative in replacement of diazepam. Any comment from the doc?
So thank you. Yeah, thank you for this question. And yes, in places where there's no diazepam, we actually look at membrane stability and action potential points. And phenobarb and carbamazepine are things that have often been used. However, that's not something that we actually recommend. We actually even recommend sodium divalproate, which is even more effective when you look at the mechanism of action. But needless to say, in remote areas where there is no diazepam, then it's not the right thing to do. It's not the correct. Clinically, it's been shown, studies have shown that it's not effective. However, we do look at the risks assessment and we do give phenobarb. So your question, I would like to answer it in this way to say, look, if you don't have diazepam, then please go ahead and give phenobarb according to the titration. And again, it shouldn't be a regimen that you give and you also discharge the patient on that. That is wrong practice. However, in order to save that life, in that particular moment, we actually do guide and we support according to that particular scenario. Over.
Thank you so much. I think we've had quite some great discussions, great sessions this afternoon. Thank you everybody for joining us. At this time, I just want to ask Dr. Dalao if you have any final comments you would like to make, some points of emphasis as we continue to fight the cholera outbreak, as we continue to receive our patients. What are some of the pearls that you want to just ensure that our staff are able to keep in mind as they're managing patients?
Yes, just to guide Dr. Kuzja, that through case management, Dr. Sifiliat, we'll be pushing out the cholera treatment guidelines, and all of these clinical polls will be in that. And in addition to that, we'll be rolling out webinars specific for management guidelines, the same management guidelines in this week. So please, the way they've joined this, please join that so that we can do that. In addition to that, we also welcome consultancies. We are available over the phone, on WhatsApp. So please, I will be sharing my phone number on this platform here. So please feel free to consult if you have cases, and we are here to support. Over.
Thank you so much, Dr. Dalao. Dr. Sigide, any final comments as we wrap up?
Yeah, thanks, Dr. Jambo, and thank you, Network, for connecting. Yeah, so the epidemic rages on, and we are still asking that we improve in how we take care of patients, especially with these comorbidities. We are seeing quite a lot of comorbidities, alcohol, and this interaction with cholera is one of them, but we are seeing a lot of HIV as well in the centers. We're seeing a lot of TB, a lot of cardiac patients, chronic liver disease, and renal patients as well. So just like those taking care of these patients to be on the lookout. If there's any Anything unclear, please feel free to contact us. I think all of us have seen that our case fatality rate has been quite high in this epidemic, and probably unacceptably high. We need to work harder to reduce it and save our people. Thank you.
Thank you so much. We appreciate everybody's contributions, comments. Thank you very much, and for hanging on until this late. We appreciate. I think we'll come to the close of this session, and then we'll be able to meet again. So tomorrow we have a session on COVID, because COVID is also another issue that has come up. We're recording a number of rising cases, and we do know that we have been overwhelmed by cholera, but we will have some reminder sessions tomorrow starting at 12. We'll have a discussion on outpatient management of COVID and the available options. So for all those that are seeing COVID cases, just refreshers, and we know that we've been joined by a number of health workers, so that you may also be oriented on how to manage COVID as an outpatient. Then on Wednesday, again at 12 to 13, we'll have another session when we'll talk about inpatient management of COVID. So do join us tomorrow, and we'll see you again. Have a good day. Bye-bye.
All right, thank you.